let's look at what we're going to chat about. We might hit the case studies before the break, but we're going to look at what it is, understanding your runner. We're going to look at some run biomechanics, obviously the risk factors, what's brought me onto what I'm presenting today, and how I assess my runners. And then we're going to look at some case studies. Don't worry about the random names. I've got 6 different videos, presentations of some of the common things we might treat for our running patients. And here you go. We've got, this should not be news to anyone, Nita wall, lumbar range, straight leg raise, and your Thomas test. And then I'm looking at foot type. I often will take a little goniometer and measure their hallux extension. And then here you've got a Craig's test. So Craig's test, they're prone. I palpate the greater trochanter. And then when that's in a neutral position, I'm noting the amount of external rotation. It should be within 15 degrees. Is it equal? More often than not, they can overcompensate and drop a shoulder, but the shoulder height will be equal, but the hip height isn't. So you know there's some side flexion happening through the trunk. What is the trunk posture? You're going to see that forward lean classic. This is a common error I see. Forward lean from the waist, running with their bum sticking out. Or are they just very hunched and improving their posture? This issue, why does it hurt? And it was previously thought to be a friction syndrome. In fact, there was also talk about an ITB bursa, a little bursa beneath that. I think sometimes, I mean, they say that it doesn't exist, but there's enough anatomy books out there showing it. So possibly there's a bursa under the tendon. But actually, and what's happening that, is that tendon actually shifting anteriorly and posteriorly past the lateral epicondyle once you hit 30 degrees of flexion? Or is it just actually a shift in the fibers and the direction of the fibers? But we do know that there is some compression, and it's thought now that the pain is actually an impingement syndrome, particularly of this highly innervated and vascularized sensitive adipose tissue that sits between the ITB